speakers who will speak to us today. And the speaker, as you know, is Kimberly Samkoe. So many of you know Kim, I'm sure, and she completed all of her degree work in Canada, culminating at the University of Calgary with a PhD in physical biochemistry. Did some PDT work, first came to Thayer as a postdoc to continue working in PDT. Another time, went to the Geisel School of Medicine as a professor of surgery. We were fortunate enough to recruit her back here to Thayer to be an associate professor in the engineering school. She works, as you can tell by the title of her talk, and is going to present to you today. Maybe she'll say something about PDT, perhaps, if she continues to work in that area, but more so in fluorescence-guided surgery. We're trying to use fluorescence signals that come off of tissues, sometimes endogenously, sometimes from an exogenous an agent that's delivered to the patient to try to inform surgical procedures. So, Kim, thanks for coming and being here. And we're looking forward to hearing from you.
All right. All right, thank you. It's my pleasure today to talk to you about what the research we've been doing in my laboratory over the past few years, which really is centered in fluorescence molecular imaging and oncology. So to start off, I'll just, because I know not everybody is familiar with cancer, cancer can be described by a number of biological hallmarks or characteristics that describe its behavior and the differences between normal tissue. A lot of these differences, though, that are summarized up here really stem from cell signaling that has gone awry. So either too much cell signaling or not enough cell signaling. Some of these differences come from protein overexpression. So we all have proteins on the outside of our cells that are used for cell signaling, transferring signals from the outside of the cell to the inside of the cell. And oftentimes in cancer, things like growth factors that help tissues grow faster and become invasive are overexpressed, which means that they have a number of extra copies on the cell. And so the receptors are more concentrated. Therefore, the cells can utilize this to grow faster and outcompete the normal cells. Additionally, we can have protein dysfunction. If you've ever worked in biology, you've probably heard structure as function. So the structure of a protein is really important in how it works. If there's a genetic mutation or a misplaced amino acid, the structure of your protein may be different, and therefore it either doesn't work, and some cell signaling process that is important might not happen, or it works too well and it amplifies a cell signaling process. And so the work that we do in our lab is to utilize these differences in cancer tissue from normal tissue to try and understand them more and develop clinical applications that will help patients. So typically these differences in protein function and concentration are measured in patients by taking tissue out of the body and then either cutting it up or homogenizing it or breaking it down into single cells. And from this point, then, proteins are measured using a number of different techniques, which you can see aligning the bottom of the slide. And so this is great because we can actually get information about the protein that we're interested in. It can help in diagnostic, help in treatment determinations. But the problem with this is that it's a single sample. It's highly invasive. You actually have to go surgically or with a biopsy needle into a patient and physically remove tissue, which increases chances of bleeding, it increases chances of infection, and then you're only getting a single time point snapshot of what that protein would look like. Also spatially, we're taking a very small sample of the tissue, and tumors can be quite large. They can also be quite heterogeneous, and so we're not really understanding the full spatial dynamics of protein expression and function. And so really what our lab works to do is to take these technologies and try to move them inside the human body so that we don't actually have to remove the tissue. And we can look at both structure and function over time. So the way we do that is using fluorescence molecular imaging. Optical imaging tends to be highly specific for molecular sensitivity. And so what that means is we can actually observe really low concentrations of proteins within the human body. And we can also span several orders of magnitude in spatial resolution. So we can use microscopy and see things at a single cell level. We can also look macroscopically up in the millimeter level and actually image in humans. And this is different. Both SPECT and PET are other medical imaging technologies that have high molecular sensitivity, but they don't have this really high spatial sensitivity. And so on the right-hand side, you'll see a series of images popping up. The top image is fluorescence imaging in a patient, and the bottom imaging is fluorescence imaging microscopically of single cells. And so the agents that we use that target these extracellular receptors on protein cells can be imaged through the entire surgical pathological workflow, and we can gain the same information we can gain information at every level. But the real key to this is that we are able in a human to visualize microscopic information at a macroscopic level and then try to get quantitative information from it. Now, how do we do this? So we take these proteins that are on the outside of cells. We call them either molecular targets or biomarkers. And there's a number of different imaging agents and therapeutic agents that are made to target these. So oftentimes we just lift these out of therapeutic agents. They're already being made by the pharmaceutical companies, and we simply just tag them with a fluorophore. We can also help design new proteins or new imaging agents from scratch. And so these can really vary in size from small molecule inhibitors all the way up to nanoparticles. But the key is we tag them with a fluorescent label, and then these molecular agents can then bind to the biomarker that we're interested in on the cell surface. Now, for those of you who are familiar with fluorescence microscopy, you might see images like this that are quite beautiful. You can look at multiple different colors. You can look at multiple different structures at very high resolution. But one of the keys of this is that you incubate your cells or your tissue that are very thin, so either single cells or very thinly sliced tissues at the micron or nanometer level with fluorophores, and then you wash away all the extra fluorophores. So all you're really seeing is the fluorophore that's bound to that structure that you're interested in. When we move up to larger biological species or thicker tissue, this beautiful resolution does not move up with it. So what happens is when we administer a fluorescent agent to a human, it goes into the bloodstream, it goes everywhere in the body, everything becomes fluorescent. And then what you do is you wait for a differential clearance between the tumor and the normal tissue. And this differential clearance is going to be the way that we see contrast. And this is actually how most medical diagnostic imaging works. If you've ever had an MRI or a CT scan, this is all the same. It's differential clearance between two different types of tissues. However, which I'll get into in a minute, with fluorescence, this is actually really qualitative imaging. It is not at all quantitative. But how does molecular targeting actually help? So instead of just using a single fluorophore that is not targeted to an agent of interest, so cancers, I said there's differential clearance between tumor and normal tissue, and part of that differential clearance comes from the inherent properties, these hallmarks of cancer. So they have an overgrowth of vasculature. That vasculature is not well formed. It tends to be leaky. And so more gets out of the vessels than it does in the normal tissue. It also tends to not clear very well. So the lymphatic system, which is responsible for clearing the normal fluid around our cells, is not functionally working as well, or the pressure of the tumor growing has actually closed them off completely. And so what happens is in tumors, just naturally, even if we don't have anything targeted, we get a buildup of anything that you inject into the bloodstream in the tumor. And so this could be nutrients for cells, for the cells themselves, but it could also be the imaging agents that we inject. So if you look at this curve here, the red curve is representative of the blood plasma distribution. The green curve is the tumor perfusion, and the blue curve is the normal tissue. So initially, we can't tell any difference between these tissues, but at later time points when this differential clearance is happening, we can start looking at the difference based on intensity, okay? So what molecular targeting actually does is that increases that difference between the normal and the diseased tissue. The targeted agents actually bind to the cells, and so they're retained even longer than they would be if they were just free. And so we get an additional boost in contrast. So if we're just thinking about fluorescence intensity, we get this boost in contrast, and we can more easily, or the theory is we can more easily determine tumor from normal tissue based on this increased contrast. Now, this is highly dependent too on the size and the pharmacokinetic and the pharmacodynamic properties of these agents. And so that is a lot of what my lab does. I'm not going to talk a lot about that today. But I just want to point out before I get started, and really where the field of our work lies, is that intensity-based fluorescence imaging in thick tissue samples, such as a person, is non-quantitative. Fluorescence intensity varies really widely with the concentration of your imaging agent and the depth at which the thing that you're imaging is at. So for instance, we can look at two scenarios. On the left is a scenario 1 where we have two inclusions. They're at the same depth below the surface of the tissue, but they have different concentrations of fluorophores. And we see that as this fluorescence image on the left-hand side where one is bright and the other one is dim, right? But this could also be a scenario where the two inclusions have the same concentration, but are at different depths. The deeper something is in the tissue, the less fluorescence is going to make it back up to the surface. And the reason for that is that light path through a tissue is not linear. So in very thin tissues, such as cell culture or thinly sliced tissue in microscopy, the relationship is linear. But in thick tissue, it's actually exponential. You can see that on this image right here, where we have decreasing intensity, but also this exponential relationship between depth and intensity. It also takes into effect optical properties. So how much light can the tissue absorb and how much light can the tissue scatter? These are also not linear with intensity. Scattering can actually increase fluorescence intensity. Absorption decreases fluorescence intensity. This also depends on what wavelength you use because wavelengths travel through tissue at different depths. So low wavelength light with high energy can't get very far into the tissue, maybe only a few hundred micrometers. Whereas long wave light, like near infrared light that we use, can actually go down centimeters into the tissue. So these differences really make wide field imaging hard to do in humans. And finally, fluorescence intensity and contrast also depend on volume. So because we're collecting from a large field of view, if you have a very small tumor with high intensity, in a large background of low intensity, the volume of that background is going to overwhelm the signal that you have from your very small tumor. And so again, this is a nonlinear relationship. And then finally, it seems like I'm convincing you not to use fluorescence imaging, but we'll get to the point soon. Contrast can also be reduced by nonspecific binding. So it's very rarely that you get the case where the normal tissue completely clears the fluorophore and the tumor retains it so that you have a zero background signal. Fluorophores tend to be sticky. They'll stick to connective tissues, but they also just have similar pharmacokinetics. They're not that different. And so what we find is that inherently wide field imaging is qualitative. And so with that, I'm going to tell you what our lab does. So we try and take this non-quantitative method and develop imaging methodologies that make it quantitative. And so we do this in a translational sense where we're trying to move from preclinical investigation into the clinical situation where we can actually help surgeons and patients and pathologists. So our group is kind of split into both clinical and preclinical research. We also have a number of different areas of focus. One of the main focuses as my lab got started was really through detection and diagnosis, so really trying to differentiate between tissues. But we've been moving into monitoring, so therapeutic monitoring, process monitoring, as well using our quantitative methodologies. And then we have two additional fluorescence techniques, what we call single agent imaging and paired agent imaging. So single agent imaging in general is that quantitative method, but I'm still going to talk about it and its utility in the clinic. But then I'm also going to talk about the research that we're doing to make it quantitative and move it forward in order to be more diagnostic. And so I'm going to go over a series of topics today, just highlighting a few of the projects in our lab that are maybe good stories, and then I'll also highlight some of the other work that we're doing that I won't have time to talk about today. But this ranges from first-in-human clinical trials, depth imaging, margin assessment platforms, and then also molecular therapy monitoring. Okay. So I'm going to first start talking about this single agent imaging, this sort of qualitative, more qualitative assessment. But the reason I'm doing this is because there's actually been significant clinical progress with this, and Dartmouth is at one of the forefronts of this progress. And so one of the reasons that we've been using single agent fluorescence is actually to try to identify tumors. So can we identify it based on that contrast intensity alone? Can we say that the tumor is more bright than the normal tissue, and can that help surgeons actually find tumors better? And the reason for this is that if you have a surgical resection of a tumor and any tumor is left behind, you have a high chance of what we call recurrence. And this occurs in about 10% or just under 10% of all patients that undergo surgical resection. And there's a couple of reasons for this. One is sometimes the tissue is just missed. It's too small to see by eye. Because surgeons use visualization. Can they see the difference in the tissue? And they also use palpation. So they feel around to see if they can feel the difference between the normal and the tumor. The other is pathological analysis really only samples a very small amount of the tumor, approximately 1%, which is very, very small. And so a lot of times there are false negatives. And so traditional pathology, or traditional surgery, which is wide local excision surgery for solid tumors, is where a surgeon will take the tumor and take out a ring of normal tissue around the tumor. And what they're hoping is that ring of the normal tissue is a collar that prevents the outgrowth of the tumor into the normal tissue that is left behind. And so what pathologists are doing is they're really trying to check that ring of normal tissue around the outside to make sure that there's no cancer that's visible, so that they know that the surgeon got all the tumor out. During the surgery, the surgeon can send what's called frozen sections down to the pathology lab. These are tiny biopsies from the boundary of the tumor or the actual surgical space itself. These are analyzed by the pathologist in real time, and then the results are sent back to the doctor. These are pretty accurate in terms of diagnostics, but what happens is the surgeon has taken out this little tiny piece of tumor from a large wound bed, sent it to a pathologist, and the pathologist says, yes, it's positive, but then can they find exactly where that spot was again? It's very difficult. So although they're highly diagnostically accurate, they're not very good at helping the surgeon make sure all the tumor is cleared out. Then when the whole sample is taken out, again, that sample is sent down for pathology to see if there's any residual tumor in the margin. These results can take 3 to 7 days. So the patient has obviously done surgery at this point. If they find a positive margin, that means that the patient either has to go back into surgery or they need to adjust their adjuvant care so that they're treating for tumor that's still existing in the wound site. So it hasn't gotten everything out. So fluorescence-guided surgery has been increasing in popularity as a way to help surgeons and pathologists see the tumor better. Indocyanine green, or ICG, has been used in fluorescence-guided surgery or in surgery for decades. It was approved back in the 50s, but it's typically used for angiography imaging, so just imaging blood flow. In the last decade or so, there's been a lot of push to use it for imaging tumors, but ICG is non-targeted. Here at Dartmouth, I was not involved with this, but Keith was. ALA protoporphyrin 9, which is a metabolic fluorophore. It's given as a non-fluorescent agent, and then our tissues actually create the fluorophore from the starter. This was clinically approved. We also have receptor targeted and enzyme targeted. So this is really more the frame where I'm working in, where we're looking at targeting proteins of interest. And these are, for example, folate cancer and ovarian and lung cancer, cathepsin and breast cancer, and then epidermal growth factor receptors for epithelial cancers such as head and neck cancers. So as you can see by this timeline, these are the only 4 imaging agents that are clinically approved, and 3 of them have been approved in the last decade. 2 of them have been approved in the last 3 years. or 4 years. And so there's a number of fluorophores that are coming up through clinical trials. There's actually hundreds of clinical trials ongoing right now for fluorescence-guided surgery. And so we are also looking at fluorescence-guided surgery with just a single fluorescent agent. And our goal, again, is to help surgeons navigate to see the tumor better through contrast. Can you guys mute? Okay, perfect. All right. We also are looking at methods to standardize the analysis of it. So even though the signal might not be quantitative, we might be able to get some quantitative information out of the analysis, and then also ways to provide the information to the surgeons and the pathologists that don't mean they have to be able to understand fluorescence intensity. We're looking at, can we provide them in like a probability of cancer being present? And so what we've been doing for the past, I guess, probably a decade now, is using a small synthetic peptide called ABY029. It is targeted for epithelial growth factor receptor, which is an extracellular protein that is, it's a growth factor, so it helps tumors grow and invade their surrounding area. And it's highly overexpressed in many different cancers. The highlighted ones are ones that we've studied here at Dartmouth. The other thing about this agent is it's very small, which means it goes through the body quite rapidly. We can inject it in the pre-surgical suite, and we can be imaging it in the surgical suite within a couple of hours. And then it has no immunogenicity that has been observed either in the toxicity studies or within the humans that we've tested it with. And so, this is a really promising agent. One of the, I would say, the direct competitors is an antibody agent, but that can take hours to days in order to be able to see contrast. So typically patients have to come in 24 to 72 hours before their surgery to get the injection. And if you look around our surrounding area, that doesn't work very well in rural communities such as ourselves, where patients have to take days off of work just to come in for a single surgery. And so hopefully this will be beneficial. So we did 3 phase 0 clinical trials. I was only involved in 2, so I'm just going to talk about those. The soft tissue sarcoma is the first. And so all of the imaging we did was in the pathology suite. We weren't actually imaging in the patient themselves, but our goals of these were to see, can we see our imaging agent, and is it specific for EGFR? And so what we did is we took these tumors out, we sliced them up. Soft tissue sarcomas are known to be highly heterogeneous, and they can actually be quite big. So I think our smallest tumor was about the size of a golf ball, and then we had other tumors that were larger than a football. So like, we didn't take the whole tumor, we were just taking small pieces and trying to correlate high and low fluorescence. Here is an example of what those look like. We have our tumor. This is an actual bread loaf slice, so one of the cross-sectional slices. We removed smaller pieces, we looked at that fluorescent, and we correlate fluorescence, and we correlated those to pathology. And so here, the brown color is the expression of the protein. That's one of these ex vivo techniques that are typically used for protein expression. And our fluorophore, the more that's present is going to be orange, and then it fades down into this purple color. So higher concentrations are going to be in the green, yellow, and orange phase. And so we can look at a number of parameters. We can look at just fluorescence intensity. And what we found is we injected 3 doses. Fluorescence intensity increases in the tumor with each dose, but it also increased in the background. So we weren't getting a bigger separation with more dose that we were finding, but it was becoming more detectable. So what we found is really a microdose, which is a 30 nanomoles, so a very small amount. Was not really detectable in large amounts of tissue using surgical systems. It was in the more specific systems that we were looking at. But what you can see here is the contrast, and we looked at a number of different types of contrast. Biological variance is essentially signal to noise. Tumor to background is really just intensity in the tumor divided by intensity in normal. And then contrast to variance takes both the intensity and the variance in both the normal and the background. And it turns out the contrast to variance seems to be the more stable value. But the surgical standard, I would say, is the tumor to background. And I'm sorry, but somehow it seems like I'm missing a graph here, but this was going to show that we had high correlation between EGFR expression, so this brown color, and the fluorescence intensity. But somehow it got deleted. So, head and neck, we saw similar results. A slightly different study. We still looked at those cross-sectional sections, but we also took margin biopsies. You can see the images on the bottom there with both the immunohistochemistry and the corresponding fluorescence in a number of different imaging systems. Again, we saw the same correlation. Fluorescence increased in the tumor, but also increased in the normal tissue. But here you can see different indication, different tumor. We actually had a little bit better of a response over the 3 doses. So we actually saw slightly higher contrast in the highest concentration that we administered. Interestingly, the moderate dose actually had the best area under the curve for our ROC. But when we're looking for absolute diagnostic power, the highest dose had the highest sensitivity. So if you look at this black line, ideally you'd want this black line to follow all the way across. But it follows this top portion further than the moderate dose, which just means that we have higher sensitivity. And then interestingly, with the biopsy samples, we did see a significant difference with intensity. But again, these are very small tissue samples. But that's really promising, even just for screening frozen sections, because they typically take so long to perform. So overall, this is, even though we're just looking at intensity, and I know I just really down-talked intensity-based imaging in my introduction, but we actually see really good results from this. But the question is, can we do better? And that's really where our preclinical work is coming in, is trying to improve these even further, because fluorescence-guided surgery is really taking off and is highly promising. One way that we're doing this, even with single-agent imaging, is through machine learning. And so we performed a radiomics study, which we called optomics because it's optics and not radiology. But we looked at a number of different, this is using the Python machine learning package. We looked at a number of different ways to analyze this, and it's really looking at fluorescence intensity distribution versus intensity itself. So how does a pixel with fluorescence relate to its neighbor? And the overall conclusion is that this actually performs much better than fluorescence alone, just fluorescence intensity. We were able to increase our accuracy from about 80% accuracy to about 94% accuracy, just through these machine learning technologies. The limitation to all of these first-in-human studies, though, is that there was a very small sample number. We only had 12 patients in total, which is part of a phase 0 trial. And so we're moving into phase 1 studies. And as we do that, hopefully we'll be able to get more statistics. It's actually really surprising that we were able to get anything that was statistically relevant. But one of the other outcomes of this machine learning is that we can actually take the fluorescence imaging and we can project it in probability of tumor. So we can look here that the high signal here means 100% tumor and low signal means 0% tumor. So instead of saying this is fluorescently intense, which these boundaries typically are, we can say that these are low probability of being a tumor because they're not close to this large tumor bed. And so it makes the interpretation a little bit easier. And so right now what we're doing is we're moving towards phase 1 trials. And we have completed pretty much all of the work, IND approval. I think we're on the cusp of getting our IRB approval, and we should be recruiting patients for the phase 1 trials within the next couple of months. But again, really promising work, but we're always trying to make improvements. And so this is where I'm going to move forward talking about this. But after each little section, I'm going to give the people behind the research. These are really just the students and staff that have been in my research group that are directly working on this. So we have students, maybe not necessarily even working on ABY. We have some students who are, but then also expanding it to other techniques. So we're expanding to start looking at ovarian cancer, and then also looking at image registration and analysis, also different types of numerical modeling to try to model the different fluorophore types. So these are the students who helped with that research. So So as we move forward, one of the things that we're interested in is making surgery to be more like the GPS compared to a map. So when I moved to Dartmouth 17 years ago, I moved here with one of those like map atlas books, right? It was like all of the states and provinces in North America had its own map, and that is how I drove down here. But today we have GPS, right? We just plug in our phone, we get told where to go. We even get told if there's a traffic stop up ahead, if there's a snowstorm coming in. And so these are really, if we just look at the last even 15 to 20 years, there have been major advances in how we get around the world. And this can be equated to surgery. Currently, surgery is like driving around with a map of North America on your passenger seat. It's not very good. It's accurate, right? Like we know where all the roads are, but in real time as we're driving, it's very easy to get lost. You have to stop to ask directions. You might get caught in a snowstorm. And so what we're really trying to do is move surgery into that GPS world. Can we see what we're doing in real time? Can we tell surgeons without interruptions to the surgery what they're seeing that's maybe hidden from view? And so this is really the focus of a large project that we just put together and was awarded last year through the ARPA-H program. ARPA is the Advanced Research Projects Agency for Health. They have a program called Precision Surgical Innovations, and they were specifically looking for this sort of roadmap guide, this GPS for surgery. And so we put together a fairly large team. I lead it of the whole program. Eric Henderson, who is here in the audience, is the clinical director. We have a number of different teams that are focusing on different aspects of the project, ranging from instrumentation to actually clinical simulation. We have several Thayer faculty involved, Ryan Halter, Keith Paulson. Summer Gibbs is an alumni of Thayer. She received her PhD here in, I think, 2007 or 2008. We also have a number of cross-teams cores. These are technologies and methodologies that are supporting the development of each of the teams. Again, we have some Thayer input here. Scott Davis is the leader of the technical quantification and validation. And Ethan LaRochelle is also an alumni of Dartmouth, and his company, Cal Imaging, is helping us with phantom validation. And so our multimodal end-to-end solution is looking at, we're not actually looking at cancer here. Our goal is to do this during cancer surgery, but it is to look at nerves and blood vessels and try to actually avoid them. So we want to actually save normal critical tissues here. And the way we're doing that is with surprise fluorescence imaging and optical property imaging as well. And that is what I'll be focusing on as I pass the slide, because that is my contribution to the project. But we're also looking at that visualization and interpretations. We're trying to take multiple imaging streams, pre-surgical CT, intraoperative ultrasound, fluorescence imaging, optical property imaging, and feeding it into a single readable quantitative value for a surgeon that can be interpreted in real time and guide surgery without any interruptions. We're also developing new imaging agents. So Summer Gibbs has been working on novel nerve fluorescence agents that can allow for nerve-sparing surgery. And then one of the keys, I think, for our project is we spent a lot of time deciding how do we actually validate the techniques that we're looking at, and we've come up with a number of techniques, include hyperspectral cryoimaging for tissue, and then also a lot of instrumentation and anatomical tissue phantoms that will allow us to check our results and then check between institutions. I didn't mention this, but there's 6 institutions other than ourselves in this project, so it's quite large. But the contribution that my lab is making to this is through a technique that we call multi-excitation wavelength emission ratio, or MUER. This is, it's a bit of a mouthful, but this is a single agent technique, but what we're actually doing is we're actually utilizing that depth penetration of the light in a novel way in order to pull out quantitative depth. And so if you have a fluorescent molecule, you have what you call an excitation spectrum. That is the wavelengths of light that this molecule is going to absorb. And then you have an emission spectrum, which is the wavelengths of light that it emits out. And so what we can do is we can monitor the emission at a single channel, so at the same wavelength, but we can adjust our excitation wavelength. So if we you can see here, this green line basically represents the efficiency of absorption. So this black line is going to absorb more light at this wavelength than this yellow line here because the absorption spectra is higher. And what that means is, and there's also a depth aspect to this as well. Different wavelengths of light travel at different depths through the tissue, and this is highly dependent on optical properties. And so what you can see here is this on the right-hand side is a graph that represents the fluorescence emission, so measured in this gray box area, of each one of these different excitations. And you can see that they vary in intensity, and then the actual shape of their curve differs as well with depth. And that is the factor that we're utilizing. What you can do is you can ratio these images. So almost everything we do is ratiometric imaging, but you can take a ratio of the fluorescence intensities, collected at two different excitation wavelengths, and you will find that there is a linear relationship with depth, where the slope and the y-intercept are going to depend on the optical properties of the tissue. So in this case here, we were using phantoms that were designed by Cal Imaging, and so we knew the depths of our inclusion, but if you don't know the depths of the inclusion, what you need to know are the optical properties. And so we're also devising methods of looking at optical properties. This is specifically for prostate cancer, so we're looking at robotic laparoscopic surgery of cancer, and we have a collaborator at Johns Hopkins University that has developed speckle imaging, speckle illumination spatial frequency domain imaging, or SISFDI, which can image optical properties through a laparoscope. And so this is the general idea. Again, we're not very far into this project. We're only 6 months in. And part of the project was it was supposed to be like a novel technique, so we weren't supposed to have years and years of background data on this. So, but it's actually really exciting so far. We've been mostly imaging in phantoms, so tissue phantoms that we can change optical properties with by changing blood and intralipid or scattering medium. Across the top, you can see that we're collecting different fluorescence images. We have these fluorescence inclusions. They're simply just glass capillary tubes filled with fluorophore that we've put into these gelatin phantoms, but we know the depth. We can measure them, and it's highly standardized. We can also measure the optical properties, so we measure both fluorescence and optical properties. And then we can mathematically manipulate the data, and what we find is that when we use wavelengths that are close together, where there is a very small change in optical properties, we don't get a very good fit with depth. But this is expected. The line of origin here is the expected depth. When we do use wavelengths that are far apart from each other and have a larger difference in optical properties, we actually get a very nice linear relationship up to the limit of depth at which those wavelengths can image, right? And so this is why in the previous one, I didn't mention this. Let me just go back really quickly though. This is why we're using multiple wavelengths, is because depending on the wavelengths that you combined, you can actually get different resolutions of depth imaging. So when they're closer together, we can image deeper, but we don't have that much resolution between each step of the depth. Whereas if we use two wavelengths that are really far apart, you get a much steeper slope. So that means we're better able to tell how deep the tissue is, or we think we will be able to. So the good news is the goal of the project is to image up to 10 millimeters with a plus or minus 2 millimeter error on it, and we're already imaging down to about 8 millimeters in phantoms. So this is probably a best case scenario, but I just want to stress right now that depth imaging during surgery is actually impossible right now, especially non-interruptive. So you can actually bring in imaging systems to image, but the surgeons have to stop, the patient has to be prepped for imaging, the image has to take on, and then the surgeon comes back. So this real-time imaging just isn't possible, so even doing it past a few millimeters is going to be very beneficial to surgeries. There's a number of variables that we have to test. The first 2 years of the project are really just trying to get the subtleties of the variabilities in the project. And so the people behind this research, both helping in the grant writing and the initial phantom work, has been Veronica Torres. Sam Streeter isn't a member of my group. Sorry, he is a research faculty, an assistant faculty at Dartmouth Hitchcock, but I'm going to take credit for him anyway right now. No, he's just been very helpful, and I couldn't put the slide up without actually having his face on it because he has been instrumental in some of the initial data collection. Hung is also working on some of the numerical modeling. We're just getting that going. So instead of making thousands of phantoms that have different properties, we're actually going to use Monte Carlo simulation in order to try and optimize our conditions. And then, of course, Sarah, who is our program manager, and hasn't been working on the research, but has been helping with the regulatory work, the surgeon interviews and such, which are also a large part of our program. Okay. So I'm going to move on now. So that was our first technique. We're still using single agent imaging, but it's now quantitative, right? We can quantitatively determine depth. So I'm going to move into a new phase. We're going to move back to cancer surgery. One of the methods that is being used right now in the clinic for determining whether tumor boundaries have positive margin or not is something called sentinel margin detection. And so what's happening here is the surgeons are taking the tumor out and they're measuring that outside edge of the tumor to see if they see any fluorescent hotspots. And they're correlating fluorescent hotspots to the presence of tumor. And this does actually fairly well. In about 5 millimeters depth, they can determine whether or not there is margin there is tumor in the margin. The problem with this, though, is that scattered fluorescence, I've talked about this issue with depth imaging, the background noise, and the volume imaging, is that they're imaging normal tissue, which should have low fluorescence, over top of a large tumor that should have really bright fluorescence. And so even though that tumor is at depth, light is going to be scattering back up and producing background signal that is going to be actually quite high. And so if we have a margin, if this lighter region is supposed to be our margin that's clear of tumor, we can have different scenarios where we have a large volume of tumor that's very close to the surface, a smaller volume of tumor that's really close to the surface, and then maybe even like a satellite of tumor, just a dot or a small grouping of cells. And the thing is when we're measuring this sort of top-down surface, is that we're likely not going to be able to see that microscopic bit of tumor because even though the signal might be bright in it, the background is going to be too bright. And so we've thought about this a lot, and one of the things we know in fluorescence imaging is that fluorescent contrast varies with volume. Again, we can see the sort of progression from in a patient to very thin. So this is, a patient is centimeters thick, right? And on this far side, we scanned 4 micron sliced tissue. So you can see we really get very high diagnostic accuracy and resolution on the right-hand side and just really kind of low signal on the left-hand side. And so how do we overcome this? So we've been developing methods for this, and specifically we've been focusing on a surgical resection technique that's used in non-melanoma skin cancers. And so non-melanoma skin cancers are very prominent. They're one of the most diagnosed tumors, but they're also one that is healed or that is cured the most often. So they really have very low recurrence rates, down around 1%. One of the reasons for this is we can see our skin, right? It's very easy to say something on our skin doesn't look right, and so diagnosis can happen early. But the other reason for this is the type of surgical resection that they use. It's called, more commonly you might hear it called Mohs surgery, but it's called peripheral and deep en-face margin assessment. So PDEMA, if you will. So what happens here is they're actually doing sort of like the sentinel margin method, but what they're doing is they're taking that bulk tumor out. It's like unwrapping a muffin. If your whole cupcake or muffin is a tumor resection and the margin is just on the outside, they're just cutting off that outside layer and laying it flat like a cupcake wrapper would be. And then they're imaging 100% of the margin surface, and so they're no longer only sampling that 1%, that very small cross-section. They're looking at the entire tumor. They're slicing through it in depth to make sure that they get tumor, see if they can see tumor at any depth. And the surgeon does this in real time. So in these PDEMA surgeries, the surgeon is also the pathologist. And so the surgeon takes out the tumor, they hand it over to histopathologists who section the tumor, stain the tissue, give it back to the surgeon, and he reads it, or she reads it, at the same time so that they can see if there's any tumor. If they see any tumor in the margin, they immediately go back to the patient, take out more tissue, and repeat this whole process. Each step of this process can take up to an hour. So if you think about, having 2 or 3 even, this is a fairly long surgery. These tumors are very small, typically up to 2 centimeters in diameter. You cannot do this for large tumors, and one of the reasons is just the time. These patients are awake during these surgeries. It's done under local anesthesia, and the patient actually usually just goes and waits in the waiting room with a piece of gauze taped over their surgical site until they know if they have tumor left over or not. And then the other limiting factor is if you get above 2 centimeters in diameter, the surface area of the tumor becomes too big for the surgeon to be able to read in a short amount of time. It'll take so much time for reading that it'll waste the day. And so what we're trying to do is see if we can take fluorescence imaging and bring it into this type of surgical analysis so that we can then bring it into surgeries that require general anesthesia and require these really long lag times in margin assessment that are 3 to 7 days. We could potentially be looking at solid tumor margins in the surgical suite within minutes of taking them out. And so this is just a simple comparison. I'm not going to go over it in depth, but just typically to diagnosis, wide local excision, which is typically done for solid tumors, is 3 to 7 days, where PDEMA is 30 to 60 minutes. And the other big difference is this general versus local anesthesia. Okay. And so because we're able to image fluorescence at each one of these stages, we can actually integrate fluorescence into the entire workflow. We can image in the patient, we can image immediately when the tissue comes out, we can manipulate the tissue, cut it how we wish, image it again. We can even image those really thin 4-micron slices. And so my lab has been fairly prominent in trying to push forward this platform. We're calling it Margin Assessment Platform, or MAP. But it uses, instead of using single agent imaging, we are using a different quantitative technique that we call paired agent imaging. And so paired agent imaging uses 2 fluorophores. One is targeted to a receptor of interest, and the other is non-targeted. So we're showing here 2 images of these 2 different colors, the targeted and non-color targeted, of a tumor that is positive for the receptor of interest and one that is negative for the receptor of interest. The white circle indicates where the tumor is in each case. And here you can see that in the negative tumor that doesn't have our receptor, it actually has higher fluorescence. This is actually not due to receptor concentration. It's not molecular imaging. It's that EPR effect that we talked about, that enhanced permeability and retention. And it also has to do with the optical properties. The tumor on the left just tends to be a very bloody tumor, and so it's absorbing a lot of the light. And so the signal actually appears lower. But if you were diagnosing this, you might mistakenly say that low signal equals no tumor. But what we can do is if we inject these simultaneously, they both distribute through the plasma, they both distribute through the intercellular space, but only the targeted one will bind. And because of that, we can actually use the untargeted agent as a control and remove the nonspecific signal from the blood and the intercellular space from the targeted signal. And we do that through a simple ratiometric method in which we take the targeted and we divide it by the untargeted image. We subtract 1. And what we end up with is a map of something called binding potential. And binding potential is simply the affinity, or how strongly that ligand receptor binds, and then the available receptor concentration. So the more receptors you have present, the higher your signal is going to be. The lower receptors you have present, the lower your signal will be. And so now this is a quantitative imaging technique versus a qualitative intensity-based imaging technique. And if you plot binding potential for these 2 tumors, you can see the one on the left actually shows that there's no receptor present or very little receptor present, whether one on the right has a large population of receptors. And so we're using this paired agent methodology. And we really took this from the PET imaging world, where they use reference tissues. But in fluorescence imaging, or in cancer imaging, you don't have another tissue in your body that mimics cancer. And so here we're able to use 2 imaging agents. We've spent the last number of years demonstrating that this is highly quantitative, correlates to in vivo pathology. We can detect very small numbers of cells. We detected down to 200 cells in lymph node, in tumor draining lymph nodes. And we also showed that it has high significance for diagnostic accuracy between patients with different expressions of EGFR, or the molecule that we're targeting, and also ones that have low expression. And so it does a much better job than single agent imaging in this respect. And so what we've looked at is we've looked at thin tissue, so we're just trying to mimic that sort of en-face margin, that margin that's cut off. These were done in mouse models of orthotopic head and neck cancer, so these are tumors in mouse tongue. So they're only about 3 to 4 millimeters thick, and as you can see here, the black line and the red line are what we're interested in comparing. When we have really high EGFR expression, we actually don't have that big of a difference between the paired agent and single agent, but the difference comes out when we decrease the tumor expression of the expression of the tumor itself, the type of tumor. So this is from a single mouse. Each one of these is an ROI curve or RFC curve from a single mouse. When we move to tumor type cohort, you can see that paired agent imaging is doing even better now than single agent imaging. And when we group all the tumors together, paired agent imaging actually does much better than single agent imaging, which shows that it provides a standardized value across patients to determine tissue instead of just intensity values. We extended this even further by looking at specifically, because the mouse tongue was already so small, it was like an en-face margin, we developed a model that would be more similar to that PDEMA surgery. So we took a bulk tumor from a mouse, we imaged it, then we cut off the margin and we imaged it again. So on the left here is the tumor, is the margin, and on the right here is that bulk amount that we cut off. And what we found is that paired agent imaging was actually able to 100% determine tumor from normal based on just the maximum signal that was observed. Fluorescence imaging, single agent imaging, or intensity-based imaging was not allowed to do that. Or not allowed, it wasn't able to do that. We also had better contrast with paired agent imaging than we did with single agent imaging. If we looked at our contrast to variance ratio, both the bulk tumor and the margin had much higher signal than single agent imaging. And then one of the key findings, which is maybe a little counterintuitive, but paired agent imaging does not vary with tumor volume. So small amounts of tumor are going to have the same signal or similar signal to very large amounts of tumor. And so this is one very important distinction from the single agent intensity-based image, which you can see on the left-hand side here, is actually related to tumor volume. The smaller the tumor is, the less fluorescent it's going to be. And so this is just showing that paired agent imaging can image margins more accurately and with higher sensitivity. The other thing that happens a lot of times in fluorescence surgery is that we simply look at one pathological slice that doesn't actually represent the three-dimensional volume that we're looking at here. So what we did is we took serial slices, we stacked them together and then compared them to the fluorescence images. And again, we found that paired agent imaging did better. We were comparing the signal here. So this red is going to be the protein expression that we're interested in, compared to paired agent imaging and single agent imaging. And in all cases, the paired agent imaging was closer spatially to being able to say where the edge of the tumor was. Okay, so that is for thick tissue, but we've also been looking at very thin tissue slices, and we've been using a value called positive probability. And so in that thick tissue, we were able to do really accurate diagnosis by just saying the maximum tumor signal, or the maximum signal in the entire tissue. Positive probability, though, is using a histogram-based analysis where we take all of the pixels at a certain value and we sum them up and we say how many of those are tumor and how many of those are normal tissue. And it turns out with paired agent imaging that a signal of 5, a binding potential of 5 in this case, is able to accurately diagnose 80% of the tumor that is present, or predict tumor with 80% positive probability. And so what we can do is we can start stratifying even these thin tissue slices by saying, does it have tumor? And if it does, you immediately go back and take out more tissue. Does it have no tumor? And we're actually really, really good at saying there's no tumor available. And so if that's the case, that tissue can just be discarded. We don't have to analyze it. We only actually have to have a pathologist look at that equivocal, so that is it tumor or not? Maybe we'll say in the 50 to 80% range of whether it's tumor. And so you can see we can do a scan of these and do this analysis in under a minute for each tissue slice. And so this is much faster than a pathologist or the surgeon sitting and reading every slice. And this way too, we can actually clear a lot of the tumor prior to that. So I'm not going to go over this workflow in great detail, but the idea is at every step of the decision tree, we're going to have a clear positive signal which says go right back into the patient. We're going to have a clear negative signal which says we no longer have to investigate that tissue. We only have a very small percentage of the tissue left that is this equivocal, or we don't know if it's tumor or not. If it's equivocal, then it has to follow down the step of the pathways. And so we're currently hopefully doing the last revision for a prospective paper in this in the Journal of Biomedical Optics. So hopefully that will be coming out soon. This is probably one of the largest projects in the group and has been going on for the longest time. A lot of the work that you saw done today was by Veronica Torres and Chung Wang. But we also have a number of people in the lab taking it beyond into other applications. We have ovarian cancer, we have tumor precursor fields, and then we also have Hung, who's working on this project, but just getting going on sort of the visualization platform aspect of it. All right, and so I just have a couple of minutes left, and I'm just going to go really quickly through this idea of monitoring therapy. And so what we're doing here is we're actually using this paired agent imaging methodology to measure available receptor concentration. So is it available for binding a therapeutic? I'm just going to flap through this background. But the key idea to this was if we put our imaging agents into an animal or a human, and then we administer a therapeutic dose of a molecular imaging agent, can we actually see it binding in real time? And so we thought this, we looked to PET data or research, and this has been done many times in PET, so we thought we would do it ourselves. So this is what we did. We injected our imaging agents, we let them come to equilibrium, then we blocked them with a large dose of therapeutic agent, and to our surprise, our single agent imaging actually caused an increase in fluorescence. This was surprising, so we did a number of control groups, positive controls, negative controls, and in every case we saw that if we weren't blocking with a targeted agent, we did not see this increase, and every time we blocked with a targeting agent, we did see this increase. But it turns out that we can actually correct for this with paired agent imaging. So because we have that ratiometric signal, we can actually correct for this, and we see what we expect to see. So here we can see an available receptor concentration, and as we inject that therapeutic agent, that signal starts to actually decrease. And so in essentially real time, we can actually start seeing molecular therapy bind and understand whether or not we're injecting the correct doses. This actually turns out that it doesn't matter on the imaging agent dose, but we have new data that shows that it does matter for the blocking dose. We can actually see differences in the blocking dose. But what I just want to show here to take home, this is the last slide, that we have ABY029, so single agent imaging here on the left in both cases, and then our paired agent imaging on the right. So this is the vehicle group. So this is injection of our imaging agents and then injecting just saline. And you can see this dashed line is where the injection happens, and you can see that there's no change in this receptor concentration here. But on the right-hand side, if you watch this tumor right here, as soon as we hit this blocking agent, you can see that the signal in the tumor starts decreasing. And so really what we're imaging here is a therapeutic agent binding to its receptor of interest in real time in a mouse. Right. And so, again, there's a large group of people behind this research. Clover and Yichen really instigated this, but it's been taken on and moving past just imaging EGFR. I'm happy to say that Divya, a project which is imaging immune checkpoint therapy, we actually just got our first provisional patent submitted last night. And so I can actually say that we're now doing this with multispectral imaging, which means that we can actually image 3 protein receptors simultaneously at the same time quantitatively. And we're also submitting our first paper on this now that the provisional patent's in, hopefully very soon. So I'm going to leave it there, just with a very big amount of acknowledgments. Obviously, this is not myself just on my own, that I have a very large group of very great students and staff that work in my lab. I also have a number of collaborators here at Dartmouth, Hitchcock, and all around North America who are fantastic to work for. And then also just a shout out to the Thayer staff who keep us all running very smoothly and are very integral in our research program. So thank you.